Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs.
Just so you all know, this program is going to be recorded today and posted on our website, cscatlanta.org/videos. In the coming weeks. So if you do want to be able to share this program or maybe just rewatch it, just so you know, that will be available and sent out to you via email as well. So we can go ahead and get started. I still have a few people jumping in, but I want to be mindful of your time, Dr. Abdalla. If you want to go ahead and start the slides.
Well, thank you, Emily, for inviting me to have the honor really to talk to as many people as possible. A lot of good things are happening in pancreatic cancer research and treatment that are pretty exciting. So I'm a surgeon and a researcher. I don't expect you to read this, but I've been working in the field of cancer surgery and research since the 90s. And I've published a lot about it. I've participated in a lot of investigations. My interest has largely been in sort of the problems that I would see in a patient who walked into my clinic. So a patient would come in and what do we do? What operations do we do? How do we do them? How do we make it safer? How do we make it better? How do we make it more effective? And so the 150 or 200 papers that I've published in the field of liver and pancreas surgery have largely surrounded these issues and have looked at better ways to merge different therapies. This is my sort of training. I did cellular and molecular biology, then I did my medical degree, then I did general surgery, then I did an additional basic science research fellowship, and then I did surgical oncology training, and then I did an NIH research fellowship, and then I went and did liver surgery overseas because at that time there was no real liver surgery training in the US, which begets my age a little bit. I've been in practice for now about 20 years. I've published a couple of hundred papers, and I've remained very active in the academic arena. And I think that this kind of sustained commitment and continued innovation, as I've continued to innovate since I've been in Atlanta only a few years, is what we need. I mean, that's what people deserve, I think, that come to see me. And I didn't really even want to start working until I felt like I was quite expert at what I did, because this is a complex problem in its simplest form. For a program to be great, it's not one person. It's an extraordinary deep team. And so, you know, Tom Brady is great, but he's great because his teams have been great. He's been able to work with people. He's been to rally support. So the same thing goes with treating complex problems like pancreas cancer. It has to be multidisciplinary. And multidisciplinary is not a word or meeting that people go to or attend, that a couple of docs chat once. It is a continuous, regular, constant communication and reassessment that happens. And that's what actually makes care better. Because your case, your personal case, is completely different than everybody else's personal case. And your personal situation is different than everybody else's personal situation. So this tailoring of care to the patient is the real fundamental aspect of multidisciplinary care, and bringing in all the different expertise you need is the way to do that. There are data that show that everything is better when you incorporate multidisciplinary care. So you actually have better oncologic outcomes. You have quicker time to treatment. Really, all the outcomes we can measure, people's lives return to normal sooner if we all work together as a team to take care of you. It actually makes healthcare professionals' lives better too. And I have to admit that when I prepared this talk, I used my real slides that I use to talk to doctors, because I need to talk up to you, not down to you. So you're going to see real surgical slides. You're going to see pictures of operations. So if you don't want to see that, be prepared. I'll try to let you know before those pictures come along. But I'm going to show you the real deal here, okay? So our multidisciplinary team keeps growing. It includes nurses, primary care doctors, imaging people, radiation providers, mid-levels, rehab, medical oncology, social work, nutrition. I have a nutritionist in my clinic who sees every one of my patients. Gastroenterology, as well as surgery and pharmacy. So there are an enormous number of elements. If you come to my office, you get a whole bunch of these in one shot. And they all really have to be state of the art, which means they're not the same day to day or year to year or month to month. We're advancing in all of these areas constantly. I came and started the program, and I'm proud to welcome my partner, Dr. Malini Sur, who's also a surgical oncologist. So our program has grown so much that we now have 2 and will fairly soon have 3 surgeons. Now, I put this slide in because your pancreas doctor can't be only a pancreas doctor, because the problems that you could have as a patient are extremely wide-ranging. So they have to have the ability to take care of a wide range of problems to the highest level of complexity. We do a lot of different operations for pancreatic tumors. One is the Whipple, which I'll talk about. One is taking out the tail of the pancreas, which I'll show you. Taking out the middle of the pancreas, taking out the whole pancreas, just taking a nodule out, which is not something we do for pancreatic cancer, but for other operations, for other diseases. We have a whole array of other operations that we do, but very important in pancreatic cancer surgery is that your surgeon has to be comfortable dealing with the critical blood vessels that live all around the pancreas. They can't go in to do your operation and have a discovery that they can't deal with. So they got to be prepared. I do a lot of liver surgery as well. This is actually important in your pancreas doc because there are an array of issues that can occur related to your pancreas, since the pancreas is connected to the liver by the bile duct, that they should be able to take care of. So we do a lot of biliary operations and revisional operations. We do some really extreme operations, including taking out parts of the liver and pancreas en bloc, which is only done by a handful of surgeons around the world. I also do a lot of robotic surgery. So many of the procedures that I do, both of the liver and the pancreas, are robotic. And we also screen. And we'll talk a little bit about a pancreatic cancer screening. So there are a huge number of elements within this area that have to be integrated to be able to deliver care. When I was asked to come to Northside, I was asked to build a pancreas program. There was no pancreas program here. We're now a high volume liver, high volume pancreas, and the highest volume robotic liver pancreas program in the state of Georgia. Northside Cancer Institute touches more than 12,000 new cancer patients in a year, which is among the top 10, possibly the top 5 in America, and thousands more than any program in the state of Georgia. which is striking. But it's because of our geography and our reach that we can do this. So sort of the father of surgical oncology was a surgeon by the name of Blake Cady. And he taught us back in the day that biology is king. That means the biologic behavior of your cancer is what really determines how your outcome will be. And he said selection is queen, meaning we've got to figure out which patients benefit from which treatments, especially surgery. And then because we're surgeons and we like surgical tricks, he said, you know, technical maneuvers are the third layer. The third layer, technical maneuvers are the prince and princess of surgical oncology. And so he taught us that sometimes surgeons try to get fancy, right? Use their technical tricks to overcome selection of the right patients and overcome the biology of the cancer. And sometimes it looked pretty good for a while, but usually you didn't have a good long-term outcome. And in fact, that was true back in the day, but I'm going to challenge this concept and give you some ideas about how we can do even better than was ever imagined could be done. So where's the pancreas? The pancreas is in the abdomen. It is a long structure that goes, and if you imagine someone laying on the table in front of you, this is the right. This liver here is on the right. This is the left. They've sort of extracted the stomach, which would be in the middle. And the pancreas is back in the back, laying behind the stomach, under the liver. And it's surrounded by critical blood vessels called the portal vein, the superior mesenteric vein, the splenic vein, which goes out to the spleen. And then these red ones are the arteries. This is the artery to the spleen, or the splenic artery. This is the artery to the liver, or the hepatic artery. And this guy underneath the pancreas is the superior mesenteric artery. That guy goes down to all the intestine. So the pancreas is intimately associated with a whole bunch of organs, which makes surgery of this pancreas quite a lot of fun. So what does it do? What does this pancreas do? The pancreas has two major roles. One is to make and secrete digestive enzymes, which go into the GI tract. And the other role is to make and secrete hormones, which are messengers that go through your blood, the most famous important of which is insulin. So going back to our slide here, digestive enzymes flow down the pancreas through this pancreatic duct and enter the intestine to help you digest your food. Bile flows out of the liver. It actually goes through the pancreas itself and joins the pancreatic duct so that your bile and pancreatic juices end up in your intestine. Food comes out of your stomach, which for whatever reason in this diagram is missing, but it flows here. So food, bile, pancreatic juice, digestion, and then everything goes downstream. And then surrounded by all these blood vessels is important because the pancreas is making many hormones, including insulin, which go into the blood and help you manage your blood sugar and many other physiologic issues. So what's pancreas cancer? Well, we just said that there's a couple different roles of the pancreas and there's different cells in the pancreas. There are a lot of cancers that can occur in the pancreas, but only one is called pancreatic cancer. That's called ductal adenocarcinoma or pancreatic adenocarcinoma. That's pancreas cancer. There are other tumors. The second most common is called a neuroendocrine tumor, which is actually an overgrowth of the hormone-producing cells in the pancreas. Completely different disease, completely different surgical approach, completely different issues. And then there are a bunch of other types that are more rare. But if you try to Google and you start mixing these together, you'll get confused because they're really different diseases, completely different diseases. So we talk about pancreatic cancer, we're talking ductal adenocarcinoma or pancreatic adenocarcinoma, and there are less than 200,000 cases of pancreatic cancer in a year in the USA. Interestingly, I have patients in their 30s and 40s with pancreas cancer now, something I don't ever remember in 30 years of doing this. So there's been a shift in the presentation of this disease, and I'm going to touch on that a little bit now. Are there early warning signs? Usually 10 early warning signs are discussed. New onset diabetes is something to be pursued. And I want anyone who's watching this to realize that just because you get diabetic doesn't mean you have pancreas cancer, or just because you get yellowing in this, or just because you get weight loss, or just because you get any of these doesn't mean you have pancreas cancer. In fact, you probably don't, but these are the signs. So sudden onset diabetes, jaundice, which is yellowing of the skin or eyes, usually preceded by changes in the urine and the stool. The urine gets dark, the stool gets light. If you've been on a diet for a year and you haven't been losing weight and suddenly you start losing weight, there's a reason that your diet, which never changed, has magically started working. So we would pursue that. Persistent abdominal and sometimes back pain. If the yellowing of skin and eyes occurs, that can lead to itchiness that's persistent. Usually the itchy and the yellow go together. And there's some more vague ones like lack of appetite, change in taste to a more metallic taste, including a distaste for alcohol, an enlarged gallbladder, very funky stools that can be sort of pale and floating and very odorous or malodorous. Rarely blood in the stool, which is dark or tarry stools. These are all signs, but they can all be signs of other things. But if any of these occur, it should probably be looked at. What are the risk factors? So again, around 10. What can we manage? Well, smoking, smoking, and smoking. This is a smoking cancer. Pancreatic cancer is much more common in smokers. Again, just because you smoke doesn't mean you get pancreas cancer, and just because you don't doesn't mean you won't. But they are risk factors. Being overweight, this is a major risk factor. Chronic diabetes, unfortunately, is a risk factor. Chronic pancreatitis is a risk factor. Exposure to certain chemicals, sometimes described as those in dry cleaning and metalworking, may be risk factors. And then there's things we can't control, like our age. The average diagnostic age is about 70. Males get it more frequently than females. African Americans in the US get it more frequently than whites. And many wonder whether that's because there's a little bit higher frequency of smoking, diabetes, and obesity in that group. Family history of pancreatic cancer and specific genes are something that we'll talk about. What are the treatments? The treatments would be clustered into 3 general types. One is the non-curative therapies that can be steps towards surgery, which is the curative therapy. That's chemo. That's targeted therapy, including biologic therapies and new or immunologic therapies. And then radiation therapy, which can be electrons, which is one kind of energy, which can be classic radiation. Cyberknife and some of these other approaches are just different ways of delivering electrons. They're no better, no worse. And then there's protons, which is a different form of energy. Again, no better, no worse. Radiotherapy is radiotherapy in terms of its effectiveness. There are non-curative therapies like ablation that's being investigated. This is not considered a standard of care. And then the real potentially curative therapy is surgery. Remember, no man or woman cures cancer. I don't cure cancer. I take them out, but you are cured if all these factors converge and things go well for you. But surgery is typically a critical piece of curative intent treatment for this disease. Chemo, there's two relatively new gold standard chemos. One is called FOLFIRINOX, which is a combination of 5-FU, some modulators called folinic acid or leucovorin. So 5-FU irinotecan, that's full and eerie, and then oxaliplatin, which is the ox. So these are three big guns that are combined together in FOLFIRINOX. It is equally effective to gemcitabine Abraxane, sometimes called Gem-Abraxane. That's a two-drug combination. It's called gemcitabine and nab-paclitaxel. Paclitaxel is a drug used for different diseases. All these drugs have positive cancer-killing effects in a huge range of tumors, but these are the two combinations that are considered top line for pancreatic cancer. There are a bunch of others. There can be oral therapy like Xeloda or capecitabine. You can use some of these drugs by themselves or in combinations that aren't so multiple. So this is like full, that's the 5-FU, and the oxaliplatin skipping the urino. You can use gemcitabine by itself. So there are a huge number of chemos, but the two gold standards are FOLFIRINOX and Gem-Abraxane. For patients with certain genetic findings, there can be special therapies. Now, something very interesting about pancreas cancer is that if you look at the genetics of the patient, not of the tumor, but of the patient, if you look at the genetics of the patient, that can uncover treatment options for their tumors. So it's kind of cool and crazy, really, if you think about it. Okay, if we take your tumor and find the genetics of your tumor, it makes sense that we could find out treatments for your tumor. Well, it turns out that's true. But importantly, if we look at the genetics of the person with the tumor, that can determine treatments for whatever tumor you have. That's pretty cool. And it's pretty new, last few years. And I'm going to talk more about the genes, but the BRCA or the breast cancer, the classic breast cancer gene. If you have the breast cancer gene, you can be treated with this particular, what's called PARP inhibitor. If you have this defect, you can be treated with some other ones. You've seen commercials for Keytruda and lung cancer on TV, I'm sure. And there are trials for a whole bunch of new therapy, including immune modulating therapies that kind of teach your immune system or unleash your immune system or unmask the cancer that's hiding from your immune system so that your immune system kills your cancer without chemo per se. So tremendous advances, a lot of these in the last 4 or 5 years. These are just earth-shattering for many patients. Pancreatic head cancer, this is a different type of picture. You can see the stomach covered up by this normal fatty layer. If you have a tumor that's hiding over here, it can be really small, but it can block off the bile duct and cause some of those symptoms where bile backs up. And instead of going in your stool and making your stool dark and normal, your stools get light. And as that bile backs up, goes into your blood and your urine gets dark and you turn yellow. So tumors in the pancreatic head, although a complicated area, are found early because they can be small, they can push on this duct and lead to yellow jaundice. A lot of patients say, is my tumor resectable? A lot of oncologists say what's resectable, and that definition is changing constantly. This is not a static discipline. Radiology reports usually miss 80% of the points that I'm looking for to determine if a tumor is resectable. Also, because we do complex vascular resections, many things that some surgeons would consider unresectable are resectable. They can be removed safely with the expectation of a spectacular outcome. So technique and experience matters as your case is being examined. And the multidisciplinary view with the radiologist there and the oncologist there and the radiation oncologist and an experienced surgeon makes an enormous difference. And that's why those multidisciplinary conferences lead to better outcomes. I can tell you that what I was taught in the 90s has almost nothing to do with what we do today. So some of our oncologists ask who should be referred and what's resectable. And I mean, those two aren't linked. Just because they think you are or aren't resectable isn't a reason to refer. Part of the referral process is giving you all the options. And honestly, if you're in good shape, you have good options. There are options. Nobody can walk into the clinic in pretty good shape, no matter what their scan looks like, no matter what the state of their disease is. There is nobody who walks into the clinic in good shape who does not have options, good options for treatment. And if you guys forget every single other slide that I showed you and remember this one, then this is the most important message that I can possibly convey. Everybody in reasonable shape has options. A whole bunch of people in bad shape have options, for God's sake. So if you're in good shape and you have cancer, there are options for you. And that's why getting that multidisciplinary conference in early is important, because you want doors to open with your treatments. You don't want doors to close. You don't want to miss opportunities. So the outcomes for cancer that spread at the time of diagnosis used to be pretty poor, but these numbers have really changed. You know, it used to be if you just give chemo, maybe a few months, but that's no longer true. This is years now. So even a few patients with metastatic pancreas cancer will be cured in the current era. So you can't just say it's metastatic, it's over, I don't want treatment. I mean, there are patients who probably shouldn't be treated, but boy, if you're in good shape and you have any state of disease, there are options. This is garbage now, 5 months. If you have a tumor that's locally difficult to deal with, back in the day, we'd say you got a year. Well, that's no longer true. These numbers have doubled and tripled and quadrupled. And we have long-term survivors with this problem. So that's garbage. That's out the door. And then with surgery, they were saying maybe a year and a half, and that's also garbage. That's out the door. So better outcomes with metastatic disease, better outcomes with unresectable disease, better outcomes with resectable disease than this nonsense that we were taught. Like I said, I'm going to talk up to you, not down to you. This is the Whipple operation. There are 6 major steps. We cut the stomach, cut the bile duct, cut the pancreas, cut the intestine, and then this whole thing comes out. And then we have to put you all back together, reconnect the pancreas, reconnect the bile duct, reconnect the stomach. So you get your digestive enzymes back, you get your bile back, you get your food back. It turns out that this new anatomic arrangement works beautifully. Digestion is normal. The 2 patients on whom I did this operation this week are both eating and walking around, and it's only Thursday. So most patients in my practice go home about the 6th or 7th day after surgery. Eating, walking, going up and down stairs, with the target of driving their car, feeling pretty good within 2 weeks of surgery. That's not the national average. The national average is closer to 2 weeks in the hospital. But I'm old and I've been doing this a long time, and so I expect my patients to do better than they do. It turns out that experience matters. This is a real data slide. It talks about hospital and surgeon volume. So if you look at hospitals that only do 1 or 2 major pancreas surgeries per year, they have a ridiculous mortality. That means 17% of their patients die. Whereas those that do more than 13 or 14 pancreatic operations per year have a much lower mortality. And our experience is quite extensive. We do a lot of pancreas surgery. In 5 years, we've had no 30-day mortalities. So we're really, really, really far ahead of the curve. But it's never going to be perfect. If you look at national data from the United States and you look at outcomes, how long do you survive after your surgery from your cancer? The lower volume hospital and the medium and the higher volume hospital, we're doing better than those benchmarks as well. This is a reflection of experience and a huge team of people that are committed to getting you better. That's because we're really focusing on all these pieces. How good is the imaging? Do we need gastroenterology to put in a stent? Are we doing good surgery and operating on the right patients? Are we delivering the right chemo or immunotherapy? If they need radiation, is it being done the way it needs to be done? Are we getting you nutritionally in good shape? This is your GI tract. This is food and bile and digestive enzymes. Are we getting you back to recovery well? And are you getting full access to the best care that exists on the earth? There are 2 general approaches to patients that turn yellow with pancreas cancer. If the scan looks good, you can rush everybody to the operating room like it's an emergency. And then some of those patients will be inoperable, and the rest will get surgery and then maybe get some treatment. Another approach, which we consider the preferred approach, is to place a stent, let the patient get some treatment, and then operate on whoever's does well. And it turns out that this approach, you get fewer patients dropping out than this approach. So if you take 100 patients and run them down this road, you get many fewer patients doing well at the end of the line than if you go down this road, with few exceptions. We wish that there was a magical test we could do when a person walks in the clinic with a new diagnosis of pancreas cancer that would say, everything's going to go great, or we're going to have problems. Or you should have surgery, or you should not have surgery. That test simply doesn't exist. So it requires a stepwise approach. And if you take a stepwise approach, the right people get surgery, and everybody in the whole group, whether they get surgery or not, does better. Here's the proof. We looked at our experience of patients who are living 5 years after surgery. And we looked at it in comparison to other studies that published data on people still alive 5 years after surgery. So we get a sense for what's the chances you're actually alive after surgery, okay? So this is a little bit old data. This is 2009, so this is more than a decade old. But these are the best data we have to look at 5-year outcomes. And remember, in cancer, Our goal isn't for you to live 1 year, 2 years, or 5 years. Our goal is for you to beat the thing completely, die of old age. But statistically, we have to pick a number, and 5 years is the magic number that we use. So when you look at this slide, all of these studies, the average patient lives less than 18 months, year and a half. When you look at our data, the average patient lives 2 years. And less than 18% of their patients are still alive 5 years later, and more than a quarter of our patients are still alive 5 years later. So why is there a difference? This is why. First, we look at how well the patient is. This is a measure of your reserve, your nutrition, and your diabetes. So no matter what your stage is, we work on this stuff. Why? Because that gives you reserve to tolerate treatment. Second, we understand what the scans mean. So we look at the scans, we say, absolutely, that can come out. That's kind of touching some blood vessels. That can't be removed, or there's spread of disease. Because each of these different groups may go down a different road of treatment. So some people say, show me my scan. So this is what the scan looks like. This is as if you're laying on the table and your head is kind of back there and your feet are down here. Got sliced through. So we're looking up. This is the right side. This is the left side. That's up, that's down. And right in the middle is this dark area, which is the tumor. That's a superior mesenteric vein. That's the big blue vein you saw in the original picture. That's a superior mesenteric artery. That's the blood vessel that supplies the intestine. These are the veins to the kidney. There's the liver over there, the colon sitting right on top, and the stomach. So there's your tumor. This is a resectable tumor because it's not touching the vein or the artery in any way. So we look at that scan, we say resectable, surgery. This tumor, you see the dark tumor, it's touching that main vein. So in fact, that's resectable too, but we're going to have to deal with that vein. We're going to have to take a piece of that vein out and repair it. But it's not touching the artery over here. Now there's 4 kinds of borderline. Usually it means the black tumor is touching the artery in some way, or the artery in the vein, or it's knocking out the vein completely. So these are different kinds of what are called borderline resectable. I was taught these are all unresectable, but with multimodality therapy, meaning chemo and radiation and surgery, this particular patient was still alive 2.5 years after surgery. This one was survived 10 years. This one is still alive 20 years later. So many of these tumor types that we were told shouldn't have surgery are people who are living 10, 20 years later. The ones we still have trouble with are when it's completely wrapping around the artery, all the way this dark stuff kind of reaches circularly around the artery. We still have trouble operating on these, but we're still working on it. After I take this tumor out, this is what it looks like. The tumor used to be sitting right here in this field, and you see the vein is pristine, the artery is pristine. This is the inferior vena cava, which is the main vein that brings blood back to your heart from your body. This is the bile duct that's been cut, and your pancreas is back there. It is absolutely pristine after surgery. So that whole block of tissue is gone. So that's not only the tumor and the portion of the pancreas that it was in, but it's all the tissues that are expendable in that area where that tumor could spread. And I take this picture after almost every operation that I do. So this should be absolutely pristine. This is a tumor that, as we freed things, is still, this is the vein. That tumor is completely plastered to the vein there. It's glued to the vein. So I got to take a chunk of that vein out. This is a diagram of what we're going to do here. Remove that vein and replace it, in this case, with another vein. So now the cancer is out, the vein is repaired. This patient is the second one you saw. This is one that's a little more extensive, and I replaced it with a synthetic vein graft. So what happens when you do that? It turns out that you get clean margins. R0 means clean. So we have a lot of clean margins. The other groups have a little lesser clean margins. And that's probably because we do a lot of vascular resection. And I started doing pancreas surgery in Florida, and then I moved to Texas, and then I moved to Beirut, I moved to France, and I moved to Georgia. And in all those places, technically on 3 continents, about a third of my patients require vascular resection. And so we have a very high clean surgery margin negative rate. We have a very good survival outcome. And I think that's one of the reasons that this is translatable around the world. This is a patient who has total tumor totally surrounding this artery and narrowing this vein. And we gave her chemo and then radiation, and then we completely replaced the artery with a vein from her leg, and then removed the tumor from the vein over here and put a patch. And 20 years later, she's a crusader for pancreatic cancer research. She's a rock star. That was unequivocally unresectable. Even today, some would consider that unresectable. But 20 years ago, we operated on her and she's still well. This is a tumor that required removal of the whole pancreas and replacement with a vein. She was the speaker at our last Lustgarten survivor fundraiser for research for pancreatic cancer. The final piece that's really important is this is multidisciplinary. Almost all of our patients get surgery plus chemo and or radiation. So this use of multidisciplinary care, not just having a meeting and say we all got together and talked, but actually doing the multidisciplinary care also translates into a much better outcome than other groups are achieving. So we're going to skip that so it makes more sense to this. When we look at patients who show up with resectable tumors, and we look at the outcome of the whole group, all the people who showed up, our average is almost 2 years. These groups, the best of the best of the best, even with surgery, they're barely accomplishing that outcome. Our outcomes are 50 to 100% better, and it's because we're delivering multimodality care. That's the message. Now, some people ask, what does it mean to get treatment before surgery? So when you show up, we have to diagnose, which typically involves a scope through the mouth into the peripancreatic area and getting a biopsy, placing a stent if you're jaundiced, getting a good scan. That can take a week or 2. We initiate nutritional rehab. And if you're going to get treatment before surgery, that phase is initially some chemo. We recheck things with scans and then start radiation if it's needed. Now, in our modern schema with newer chemo, this can be closer to 3 months and this closer to 3 weeks. So the chemo got longer before and the radiation got shorter. Then we look at folks, let them get better, let that radiation do its job, and if it looks good, get them to surgery. So surgery is at the end of this multi-step process for most patients. And I'm going to get to why that's so important. The other disease I want to talk to a little bit about is what this looks like when the tumor is in the tail of the pancreas, in the back end of the pancreas. Because we can take the tail out with the spleen and we don't have to reconstruct the stomach. We don't have to reconstruct the bile duct. And we don't have to reconstruct the pancreas. Just take the tail out. Sometimes I have to replace the arteries that go to those structures. There are other crazy things that I do, but these also lead to fabulous outcomes. So this is a tumor on the opposite side of the pancreas. This is the tail, not the head. So this patient didn't get jaundice, they just got pain. So these patients I tend to approach robotically. So they have little tiny incisions. I just yesterday did an 80-year-old who had this operation. He had a hard time with the chemo and he thought the surgery was a walk in the park. So there's not much discomfort associated with robotic surgery. And at the end of the day, if we get patients well before we operate on them, if we use good imaging and we design the treatment plan correctly at the beginning, if we do good surgery and get clean margins, use the techniques we need correctly, like vascular resection and robotics, if we deliver all the therapy that's really needed, usually prior to surgery, then you start to get the results that you should get, moving this bar forward and curing more patients. Now, the last couple slides are about pancreas cancer screening. I promised you I'd tell you about a few of the genes that are associated with a risk for development of pancreatic cancer. The most commonly heard about one is the breast cancer, ovarian cancer gene, or BRCA1. There's another breast cancer gene called PALB2. There's a FAM syndrome gene called P16 or CDKN2A. There's a gene associated with chronic pancreatitis called PRSS1. And then there are some actual colon cancer genes that can be associated with pancreatic cancer and some benign polyp colon disorders that can be associated with pancreatic cancer. And so patients with these genes are candidates for pancreatic cancer screening, just like men are candidates for prostate cancer screening, women are candidates for breast and ovarian cancer screening. And how do we do that? Well, we do that endoscopy I talked about. So they put a scope down and look at the pancreas. We do an MRI of the pancreas and we check some labs. So most of these patients get genetic counseling. We do testing, or they've been tested and that's how they got to us. We talk to the patients. They actually meet our nutritionists. They meet me. They meet my mid-levels. And then they get their MRI labs and a scope. So if that's all clear, then they're going to get a yearly MRI and labs, and typically an endoscopy or an endoscopic ultrasound every other year. The screening is tailored to each case. So most pancreas cancer screening starts at age 50 or 10 years younger than the family member that developed pancreas cancer. So if a patient develops cancer at 40, then we'll screen their kids starting 30 years old. If they got it at 70, then we'll start screening at 50. And the screening is MRI, labs, and endoscopic ultrasound. So remember what Katie said. Biology, how the cancer behaves matters. Operate on the right patients and be careful with the fancy tricks that I just showed you, because it doesn't always work. The truth is, if the techniques are sequenced and respect the biology and respect the selection, more patients can be resected with great outcomes. So the kingdom would be larger. So we are treating successfully many more patients than we were years ago. Our outcomes are enormously and dramatically better. Many more patients are being cured. Better quality of life is realized for patients across the spectrum. And it's because we're really integrating state-of-the-art everything, state-of-the-art diagnostics, endoscopy, genetics, nursing, pathology, nutrition, pain management. I hate pain. I never like to see my patients in pain. Radiation, medical oncology, and surgery. So remember, if you're in good shape, you have options. And that multidisciplinary evaluation will yield options, good ones. So we need to get patients to that kind of review early on in the trajectory of their care. I'll stop there. I'd like to again thank Emily for the opportunity to present. She's going to talk a word or two about the cancer support community. And I'm open to answer any questions that you might have. Thank you.
Thank you, Abdalla, Dr. Abdalla. That was an incredible presentation. Those videos and photos from the surgeries were amazing. And my jaw dropped when you said that thing about patients eating the week of a Whipple procedure. That's just incredible to think that people would have that kind of recovery.
Thank you. I'm happy to answer any questions.
Yes, we do have some questions. I just did want to promote the cancer support community who is putting this program on today. We are a local network partner of the world's largest provider of oncology support. And we do offer all of our programs free of charge, including programs like this education. We do stress reduction and support groups. So for more information, just go to our website, cscatlanta.org. Again, I'm the program director, and we are very proud to have a long-standing relationship with Northside Hospital, and recently reopened our new location next to Northside Atlanta. So again, if you're interested in our program, cscatlanta.org. All right. So these questions that are coming in, I think some of them you probably went over, but just to dive in again, do you, is pancreatic cancer genetic?
Probably about a third of patients with pancreas cancer, we find a gene. And that allows us to determine not only your care, because remember, what's crazy about pancreas cancer genetics is your genetics can determine your treatment. So they matter for you. You know, the genetic testing also matters for brothers, sisters, and children. But some people say, I'll only do the genetics if it's good for me, you know, or I'm adopted, why should I do genetics? And the answer is, we may find optimal treatments for you. But can pancreas cancer be genetic? Yes, it can. So what it means is that these genes that can be passed on from parents to children can put the next generation at risk. Doesn't mean they'll get it, but it puts them at anywhere from 3 to 10 to even 20 times increased risk. So pancreas cancer can be passed, and that's why screening is important, because if we catch it early, it can be cured with a much higher probability. I gave you on that one slide the genes that are known to be associated with certain pancreas cancer. We also have patients who clearly have a history of pancreas cancer in their families, and we don't have any of those genes. So there's others that exist. And this data is coming so fast. We're finding more and more links that year to year, we're adding genes that help us to identify folks who are at risk so that we can reduce their risk and relieve them of that fear of developing pancreas cancer.
Thank you. Another question. I'm a 4-year post-Whipple. Past CT showed gastric pouch with air, liquid and debris. GI doctor did endoscopy, pulmonary were good. Is there any cause for concern?
No, it's probably a functional thing that we can work out. And, you know, especially as people live longer and longer, we sometimes find these weird issues where their stomach doesn't quite empty right, or it empties the wrong way. And we usually have solutions. Most of those solutions are medical. Sometimes they require a revision, sort of rerouting the anatomy. But one big key aspect of my background was revisional gastric surgery. When I was at the University of Florida, Florida is an interesting place because of its heritage in nutrition. You know, Gatorade is from the University of Florida, and I am absolutely not a Gators fan. So if there's any Gators fan out there, I apologize. But Gatorade was developed because there's a huge nutrition program at the University of Florida, and our surgical programs there were linked to that. So we do see, and I do see folks who really don't have a cancer problem anymore, but they have some other anatomic issue that we can help with. So we do take care of those problems. And if you feel fine, who cares? There's no cancer concern if you feel fine. If you don't feel fine, then we should be able to help you feel fine. That should be something that could be corrected. There are a number of weird sort of functional issues that can occur after we rearrange the anatomy. God knew what he was doing when he put all that stuff together, and we can't put it back the way it was. So we have to be willing to be flexible. Every patient's different.
Do you recommend patients participate in clinical trials when available and applicable?
Yeah, we're very strong advocates. I mean, I've conducted innumerable clinical trials, and there are not a ton of really good surgical clinical trials out there. Most of the trials that are out there are for patients that are sort of running out of options, because the gold standard is very high. So if you have a really high gold standard option and a clinical trial is offering a really low probability of response, that may not be interesting to you. But we're very avid and aggressive supporters of clinical trials for patients in tricky situations. And we've been working with a number of institutions actually around the country to develop really innovative clinical trials for folks to push things further forward. So absolutely, yes. I think in some cases, clinical trials the first choice, but that's why you need that multidisciplinary discussion, so that a lot of different perspectives are brought to your case.
All right, we've got a couple more questions. I do want to be mindful of your time. We have gone over here. Are you doing okay?
We're okay.
All right. Some people asking about the program being recorded. Yes, it was recorded, and we will post it on the website. They want to know about sharing the slides. I'll leave that to Dr. Abdalla if he'd like to share his slides. My liver tumor tissue was examined, but not my pancreas tumor. Should I be concerned? Adenocarcinoma in the pancreas is said to be primary.
So if you had pancreatic cancer that spread to the liver, and they examined the liver tissue, for example, for genetics or what they call next generation evaluation, that would be perfectly reasonable. That would be perfectly appropriate. You still need your genetics tested, however, which is a different thing than doing next generation testing on your tumor, whether it's your primary tumor or a tumor that's spread from your pancreas to somewhere else like the liver. Also, there are rare cases of metastatic adenocarcinoma of the pancreas that we do offer surgery. So I had no idea of your case, and it's not common, but that entity does exist. So again, you really have to be evaluated by a group that thinks about all these options.
All right. One last question. My mother died of pancreatic cancer in 2010. Could I be screened though I don't have symptoms?
So very sorry to hear about your mom. Absolutely, you should be screened. So whether you had a genetic finding or not, the easiest way to sort out genetics is the person with cancer gets their genetics tested. But when that's not possible, which is true of many of our patients, but for example, your mom had pancreatic cancer, we would have you meet with a genetics counselor, and we would, regardless of your gene profile, consider you to be at increased risk for pancreas cancer. The very first pancreas cancer screening programs were designed based solely on history before we knew anything about the genetics of pancreas cancer. So a person who is well, whose mom or dad had pancreas cancer, we would recommend screening. And screening is great because it's easy. Screening is terrible because it's anxiety provoking while you're waiting for your results. So we really work to make that happen really efficiently and minimize your period of anxiety so that you feel good fast.
One last question we had come in. Who is the head chef with the multidisciplinary approach?
That is a fantastic question. I would say it shifts. So when a patient is presented at a multidisciplinary conference, we will make recommendations. I'm not going to recommend surgery yes or no to anybody that I haven't met, or certainly not surgery yes. So we'll see the imaging and the pathology. There'll be a very vigorous discussion. If chemo first is decided, then the person delivering the therapy, the oncologist, is the chef d'orchestre, is the person who's driving the boat during the chemo phase. When you move to the surgical phase, the surgeon is driving. And when you're having radiation, the radiation oncologist is driving. But in terms of decision-making, if you don't have disease that's spread, then a surgeon needs to look at your scans at some point. Even if you started chemo, it's probably 99% of the time appropriate. But get in to see, an experienced pancreas cancer surgeon to figure out when is the right timing for surgery, if there should be surgery, or what steps should be taken to get you from being a borderline patient to being a resectable patient.
All right, thank you. Are you done? Thank you so much, Dr. Abdalla. This was a wonderful presentation. I think if we go to the next slide, we'll have information about our upcoming program. But thank you for taking the time today and even going over time to answer those important questions. I know people are saying in the chat of how phenomenal of a program this was today, so they're very appreciative of that.
Well, it's a pleasure. I'm here for you guys, not for me.
Thank you. So just so everyone knows, we will have another program coming up, education about cancer involving the brain and spine with Dr. Kumar Vasudevan, and that'll be on Friday, May 13th at noon. And if you'd like to register for that program, it'll be on our website, cscatlanta.org/calendar. So register if you're interested, but thank you again, everyone, for joining us today. Again, this program was recorded and will be sent out to you all and anyone who wasn't able to join us. But thank you and have a wonderful rest of your day.
Thanks everyone who participated, and thank you, Emily, for inviting me. Appreciate it.
Absolutely. Thank you.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.